Good evening, everyone. I'm Jackie. For those of you who don't know me, I am one of the nurse practitioners in the pain clinic at DOC. I've been with DOC for 9 years. Most of my time has been spent predominantly in the pain department. I'm currently a sub-investigator for the clinical research department, and I've done that for several years. I've also spent some time in the vein department as well as our cosmetics department. So I've kind of been around and had a varied amount of experience with DOC. Again, my predominant experience has been in pain management. Um, we're going to do a presentation today on chronic migraines. Not going to do too deep of a dive into, medications and it's going to be very, very basic, very brief, just to give you a general understanding of something that is actually very common that we see in our practice. So the goals that we're trying to achieve today are just getting to know what chronic migraines are, why they occur, how to treat them, and what you can do to help manage those independently. So I wanted to start off by just giving the definition of what a migraine is. We're going to go into the breakdown of what this means for you as a patient, but this is the definition that came out in 2013 by the International Headache Society. A migraine is a complex neurological disorder characterized by attacks of severe unilateral, which means occurring on one side, pulsing head pain, and associated symptoms of nausea and vomiting, and extreme sensitivity to light and sound. I like this slide because it helps us to kind of differentiate what a migraine looks like versus a headache. So on the right, we have the symptoms of a headache. These are generally more mild, can be just a dull pressure-like sensation. It might wrap around the forehead. Some people even experience kind of a squeezing pain in the back of the head. Those are more tension type headaches. They're typically incidental and they don't recur often. And they usually don't last very long, and they're pretty easy to treat with just rest and over-the-counter medications. Migraines are, on the other hand, are typically more severe and debilitating. They present as more of an intense, pulsing, throbbing sensation. It is usually on one side of the head, but can affect both. They can last for days. You might have there. I do have another slide about different phases of a migraine, so we'll talk about that here in just a minute. They do have associated symptoms, typically nausea, dizziness. They can have auras. So you might notice prior to a migraine that you might have some visual auras, like a light blind spots or flashing or something like that. That's what an aura is. We'll talk about that a little bit more. And these are commonly reoccurring. These are the different phases of a migraine. So you might have a prodrome, which occurs 1 to 2 days prior to a migraine starting. They can have various symptoms: constipation, mood swings, food cravings, fluid retention, neck stiffness. So these can all happen a day or two prior to your migraine starting. Then you have that aura that I talked about. Could be visual, like that blinding, flashing lights. Could be vision loss, which can be scary. Can have some pins and needle sensations in your arms or legs. Can even cause some difficulty speaking or some numbness, facial numbness, or even affecting one side of the body. The actual migraine attack lasts up to 72 hours. This attack, again, those associated symptoms of the migraine: nausea, vomiting, throbbing, pulsating on one side of the head, really sensitive to lights or sounds. And then even some sensitivity to smell can happen with certain migraines. And then you have this postdrome, which is like they call the migraine hangover, which can occur for a day or two after a migraine. That can cause some fatigue, some difficulty concentrating, kind of some depression, and even some residual nausea. So anyone of you that has suffered from a chronic migraine may have experienced this to some degree, whether it be mild or moderate. Not everyone has the prodrome phase, or not everyone has the aura that helps them to kind of differentiate when this migraine is coming on. But most people do experience these attacks, which can last up to 3 days. So today we're really focused in on chronic migraines. So chronic meaning it has been ongoing for at least 3 months. The definition of a migraine, you have at least 15 headache days per month to constitute a chronic migraine, and then have those migraine symptoms for at least half of those. Maybe moderate to severe, again, so unlike just a traditional headache that might be more mild, those migraine symptoms are more severe, and they can often be disabling. They can interfere with your daily activities. Taking care of our kids, going to work, going to school, things like that can be affected by these chronic migraines. All right. How common are the migraines? 39 million Americans experience migraines, and they affect 12 to 15% of the entire US population. So those are pretty potent numbers. It can affect 3 to 5% of the US population when we're talking specifically about those chronic migraines. Again, those migraines lasting or that have been ongoing for over 3 months. Women are 2 to 3 times more affected than men. Lucky us. And there's several reasons for that. So hormonal changes. So when we talk about hormones, we talk about things like menstruation can affect it. Some people have really severe disabling migraines when it comes to cycles. It can be related to ovulation for those of us that are in childbearing years. It can be related to pregnancy. Sometimes migraines can get worse in different phases of the pregnancy, and are actually known to get better in some other phases, but tend to ramp back up after childbirth. Contraceptive use can certainly affect migraines, and menopause, which can affect migraines as well. Actually, once you get into the menopause phase, typically those migraines tend to get better and less disabling. So again, those are all the reasons that women can be more affected. It has to deal with hormonal levels in the body. Most common in adults ages 18 to 44, and certainly can affect children and teens, but we'll stick to talking really more about the adults since that's the population that we see most in pain management. How they impact daily life. So they're one of the leading causes of disability worldwide. And again, when we talk disabling, we're talking about these symptoms affecting our ability to do our day-to-day activities. They can disrupt work, sleep, and focus. So hard to focus in on a task when you have this kind of pulsating pain and the associated symptoms that come along with it. Many people underreport these or don't receive treatment. And then, effective treatment can certainly help improve your overall quality of life and your daily functions. So we'll talk about that a little bit more. How migraines are diagnosed. We do kind of go over medical history and symptoms. So what does a migraine look for you? We talk about headache diaries. So these are so important when it comes to trying to identify and really avoid triggers. We'll talk about that here in just a few minutes as well. But keeping a migraine diary or a headache diary to kind of show what these look like for you on a day-to-day basis. That way you can kind of talk to your provider and you guys can decide what type of treatment makes the most sense. Neurological exam. When we're talking about migraines, most of these neurological exams are actually very normal. When we do these certain exams, we're mainly doing them to kind of rule out any other concerning factors that may be contributing, like tumors or strokes or something like that. But most neurological exams, we're checking eye movements, we're checking strength and reflexes, and your balance can be affected too. So we're checking all of those things when we're doing the neurological exam. And we're only getting imaging when it's necessary. So just because you have a diagnosis of a chronic migraine does not mean you need to have an MRI done. There are certain red flags that we look at when it comes to those exams that really warrant getting those scans done. So again, common misconception that anybody that needs that has a migraine needs to have their brain scanned. That is not accurate. Understanding the triggers. So to treat them, it's important to understand what can cause them. So all of these factors can contribute to these migraines or bring them on. So stress and lack of sleep. I don't think any of us have those problems. Hormonal changes, like I mentioned at length earlier. Certain foods, so caffeine intake, alcohol, chocolate, salty processed foods, even additives that are put into foods can trigger migraines. Weather changes, and then just sensory overstimulation. So bright lights, certain sounds or smells, they can definitely trigger those migraines. And then again, at the bottom there, it's important to keep a log of when you have them to help find patterns and identify those triggers. Obviously, if we're able to identify those triggers, we can avoid some of those to reduce our migraine days and disability. All right, now we're going to jump into kind of the treatment overview for migraines. We're going to talk about some lifestyle changes, some non-medication therapy options, some acute treatment, which means, what are we going to do or take to get rid of this migraine when it starts, and then preventative treatment. So if you have a certain number of migraine days every month, you might qualify or benefit really from a preventative treatment. So we'll talk a little bit about that. Again, not diving too deep into the medication part, but something we'll go over. So lifestyle changes. This is kind of a framework that has been put out there that was seen on numerous literature that we were looking into while making this PowerPoint. It's called the SEEDS framework. So it talks about how migraines are influenced by sleep, eat, movement, exercise, and how we manage stress. So the SEEDS framework has to do with sleep, making sure you have a consistent sleep schedule. Exercise, regular physical activity is so important when it comes to, obviously migraine prevention, but just general health and activity. Eating consistent meals, keeping that migraine diary, and then managing stress levels. And then it just mentions that these are low risk and low cost strategies. So these are things that we can all probably do better on our day-to-day basis. So non-medication therapies, stress and mental health management. I am a big advocate for mental health and therapy. I think especially with most of our patients who are dealing with chronic pain, it's really good to have an outlet, somebody to talk to in terms of how to better manage our pain, because we know that our stress and mental health, if that's not under control, it's really difficult to manage our chronic pain. So stress, mental health management, these two therapies I specifically mentioned, cognitive behavioral therapy and biofeedback. Those are both learned and discussed with a therapist. Cognitive behavioral therapy is, again, just talk therapy, trying to see how our thoughts and feelings and responses are all kind of interconnected. So you work with a therapist and kind of identifying those things. And biofeedback is interesting and actually involves putting some sensors on your body that can record like your heart rate and your temperatures and things like that, and basically to show how your body responds. So that way you can work with the therapist to know how, when you need to intervene, when you need to do things to help kind of incorporate those relaxation techniques to better manage your stress and how you're feeling. So I thought that was interesting and probably could be a benefit to a lot of our patients suffering from not only migraines, but chronic pain in general. Acupuncture. And then this whole notion of neuromodulation devices, we do a lot with neuromodulation when it comes to chronic pain. We do it for patients that have chronic back and leg pain after back surgeries. We do it for patients with chronic neck pain that have had surgeries, or maybe for somebody that's not a surgical candidate and have been through the interventions and are still having some trouble. So neuromodulation uses electrical or magnetic stimulation to basically alter the nerve activity. So to block some of those painful signals that are traveling from those nerves and into your brain that's saying, hey, I've got this migraine, or hey, my back and legs hurt. So neuromodulation, there are some wearables that are out there on the market. Not entirely sure if you're able to get those covered by insurance. That's certainly something, if you talk to your provider, we can look into a little bit more, but there are some devices out there that help with that. All right, now we talk a little bit about the treatment. So acute treatment, again, something that you take at the onset of a migraine to help get rid of it. NSAIDs, these are the things that are easily accessible over the counter, like ibuprofen and naproxen, also diclofenac. So I just really listed, there are a lot of different medications that can be trialed. But these are the ones that I see most commonly prescribed, not only in our clinic, but just in general, even headache specialists, we see these quite a bit. And you may have even seen commercials on some of these newer ones. So again, NSAIDs, over-the-counter ibuprofen, naproxen, diclofenac is something that can be prescribed. Triptans, sumatriptan, rizatriptan, these are the brand names here: Imitrex, Relpax, Maxalt. These are the medications that you take at the onset of a migraine, and they give you the option to repeat it after about 2 hours if the migraine is still present. These GPANs, so this is the newest class of medications. Basically, their purpose is to block this chemical in the brain called a CGRP, which has a big hand in producing migraines. So it basically helps to block that chemical from being released. Ubrelvy, Nurtec, there's even a newer nasal spray, Zavsprit. These are all available on the market now. These Ditans, Rayval, we don't really see used very often. It does have some implications after you take it that you cannot drive or operate heavy machinery for 8 hours prior. So not something that we typically prescribe, but I wanted to put it out there as a potential option. I see a lot of that being used, I would say, more so for treatment-resistant migraines, simply because the other ones have less side effects and are less sedating. And then antiemetics, which is basically medications that are prescribed for nausea. I'm sure you all have heard of Zofran or Phenergan. If you do have nausea associated with your migraines, we can typically prescribe a short course of an antiemetic to help with that. This is so important, and especially affects people with our population, with the patients that we see. Medication overuse headache. Any patient that is on, whether it be over-the-counter medications, opioids, these triptans, if you utilize these acute medications more than 10 days per month, or even just the Tylenol and the NSAIDs more than 15 days per month, you could actually be contributing to your headache. It's called a rebound or medication overuse headache. So that's why if you happen to be prescribed a medication like a Imitrex or sumatriptan is the other name for it, that's why the insurance will only cover a quantity of 9 per month. It is because that research has shown us that if you take any more than that, it can actually contribute to your headache. So again, this is why it's so important that if you're having frequent migraine days, that we do try to get you on something to help prevent them versus just something to take when it comes on. Some preventative treatment options. A lot of these medications we're using off-label. So medications like Topamax and Depakote, these are long-standing migraine preventative medications that are used And they're actually anti-seizure medications, but again, we use them off-label for migraines. Blood pressure medications, beta blockers. Propranolol is probably the most common one that we see that can be prescribed. Obviously have to be careful with that one. We don't want to prescribe that for somebody that, historically has low blood pressure. So we have to keep an eye on that. There are antidepressant medications like amitriptyline, venlafaxine that are actually used at certain doses for migraine prevention. Again, this CGRP inhibitor, this blocker of this chemical, these are newer ones on the market. Qulipta, it's actually a daily oral medication. Aimovig, Ajovy, Emgality, they are 3 monthly injectable medications that you can do at home. They are dispensed in a pre-filled pen, and you're able to do those from home, and it's just once a month. So those are helpful for prevention. And then Botox, which we'll talk about that a little bit more here in just a moment. So injection options. So, as an interventional pain clinic, we have the ability to do these various injections for migraines. Botox, it's not just for fine lines and wrinkles. When we hear of Botox, we think of the cosmetic Botox that's done. We do Botox every 3 months. It can be done for migraine prevention, and it helps to kind of calm some overactive nerves. If you haven't had Botox, it's a series of injections that are administered in the face, the side of the head, the back of the head, and the back of the neck. It's a pretty easy procedure. It's actually done in clinic. It is quite a few injections, but they're very well tolerated. The procedure itself only takes about 10 to 15 minutes, probably less than that for seasoned injectors, but it's definitely something that can help, and typically lasts about 3 months on average. We also do trigger point injections. Again, if you've been a member of our pain program, these are one of the most common in-office injections that we do. A lot of people carry around a lot of tightness and tension in their muscles. So by doing some of those injections, it can help to relax those, which can, if you have tension type headaches, or this can contribute to your headaches and migraines, it can help to relax that. Occipital nerve blocks are done downstairs in the surgery center. They're very easy injections. They don't require you to be put under the big X-ray or anything. And they're just targeted injections here in the back of the head. So if you have migraines that kind of radiate into the back of the head here, that can be done. We typically see those being used more for like a migraine attack, like a flare-up. That is kind of the best situation that helps with those. And then if you have a lot going on in your neck, if you have a lot of arthritis, we typically do those cervical medial branch blocks, where we inject a medication like a numbing agent to temporarily block those pain signals. And if you get good short-term relief from those, we can actually heat those nerves up and provide some pain reduction for up to 9 to 12 months. So again, Botox and trigger points, those are typically done in office. And then we do the nerve blocks and the occipital nerve blocks and the medial branch blocks and the ablations downstairs. I think this is important, especially if maybe you haven't suffered from chronic migraines, or maybe you have and you develop some new symptoms, when to seek emergency care. They always say if you experience a sudden severe headache and it's the worst migraine or headache you've ever experienced, that always warrants a trip to the ER to have some more urgent imaging done, just to make sure there's no concerns of an aneurysm. Any kind of visual changes, again, sometimes these visual changes can happen with the aura, so that's something you just need to keep an eye on. Weakness or numbness on the side of the face or body can certainly be indicative of a stroke, so always something that needs to be worked up. Difficulty walking, speaking, fever or stiff neck could be concerns of some kind of infection going on, so that needs to be ruled out. Or of course, if you have some kind of head injury or trauma, whether it be a fall or an accident of some sort, and you have a headache, could be like a post-concussive headache, but always warrants being evaluated to just make sure there's no brain bleeds or anything like that that might be contributing. All right, key takeaways. So, migraines are treatable. It's not a one size fits all. What works for one person may not work for the other. So a lot of times when we're introducing new medications, we have to start with one drug class. And a lot of times insurance actually makes us try and fail certain drug classes before we try some of the newer ones. So it's a process, definitely something you can work with your provider on, what makes the most sense for you and what works best for you. There are certain conditions that, you can't necessarily be put on a triptan if you have, a history of, heart or vascular diseases. So we have to look at the whole picture before we start prescribing. Important to track symptoms and triggers. If you get anything out of this presentation, it is to keep that headache diary. That way you can try to see what's contributing to your symptoms to try to avoid that and reduce your headache days. And then just, we're here to help you. Make sure you're talking to your provider. Hopefully this presentation has allowed you to kind of get a better understanding of what we can do for you, what options there are out there, and then hopefully help you start the dialogue with your provider in the office to get your migraines treated better. We will open this up for questions. And of course, if you don't feel comfortable asking the questions, or you're welcome to send it to info@daytondoc.com. We're happy to respond to those via email as well.
I don't have as much of a question as to tell you that I started with migraines at 16 and I'm 71. And just until about 4 years ago, did they allow people to get to take the Quilita and the Ubrelvy and the Botox. And it was never something that was available. And between those three, I'm actually living a somewhat more normal life, but they would say, oh, it's just a headache, or oh, it's hormonal. And between people like you that allow it to be a real thing, and now there's these options of getting on this medication, it's pretty much changed my life.
I love to hear that. I am a huge advocate for these new medications that are out there on the market. Nurtec, Ubrelvy, Qulipta. They're essentially so much better than some of the older treatments too, because of the side effect profiles are just so much less. So I personally like using them. I'm a fan of Nurtec. I like to dose it initially for abortive treatment to kind of help get rid of the migraine. And then if you do well, then we can dose it actually every other day. So I'm a big fan. I've been into the injectables too, the monthly injections. I think those have been hugely beneficial for our patients as well. And then Botox, yeah. I mean, again, half the battle is getting them approved, but usually with the right documentation and the right trials, we're able to get those done. So good. I'm glad to hear that you're getting some relief.
Well, thank you.
Yeah. Anybody else have any questions? All right. Let me just put this email address on here if you have any questions. Also, this was my first time doing the Doc Talks. So if you have any feedback for me, I certainly welcome that. Hopefully be doing more of these in the future. And if you happen to see me in the office over at Woodman, make sure you say hi.